All right, today, patient-centered care, solid organ transplantation, and skin cancer. We're going to find out a little more about Dr. Jolly. Dr. Puneet Jolly, MD, PhD, attended Georgetown University, where he received his PhD and MD degrees. Dr. Jolly, welcome. Thank you so much for being here today.
Thank you so much for having me.
So let us know if we get this right. You completed your postdoctoral fellowship and dermatology residency here at UNC. And you've been on the faculty since 2012 and also work as a general dermatologist.
Correct.
Great. And founded UNC's high-risk skin cancer clinic, where they focus on treating aggressive skin cancers.
Yes.
And if we have time at the end, maybe we can talk a little bit about that. I'd love to hear more about that. And then finally, enjoys being an educator and training our next generation of dermatologists.
All correct.
Great. Well, we are really glad to have you here today. We're going to warm up our audience with a poll everywhere question. Keratinocyte neoplasms are by far the most common malignancy in the world. If you think that's true, go ahead and mark it A or true, false, B or false. While you are doing that, I'm going to put up our disclosures. I will spare you from all the words, but I've flashed those up. Let's see. I want to make, okay, accidentally went through one too quickly. So both disclosures, and we already have several answers coming in, and it looks like we're trending pretty heavily in the true vein. How are they doing?
Very well.
Great.
Impressed.
Well, off to a good start. So without further ado, solid organ transplantation and skin cancer, I'll give you the controls, and we'll let you take it away.
I appreciate it. Thank you, Tim, and the group and the audience for having me. As Tim mentioned, we'll talk about skin cancer in the context of solid organ transplantation. So the reason why this is important is your pre-presentation question was a good one. So to give you an idea of numbers, so keratinocyte skin cancers are basically basal cell skin cancers and squamous cell skin cancers. When we think of skin cancer, we usually group them into two groups. You call them non-melanoma skin cancer, and that's your basal cell and your squamous cell, and then melanoma. So non-melanoma skin cancers are by far the most common cancer that's diagnosed in the world. So we diagnose about, in this country, about 5.5 million skin cancers, basal cell and squamous cell skin cancers a year. So that gives you an idea. But the reason why I thought this would be an interesting topic is when you think about those skin cancers in the context of solid organ transplantation, it's almost a different disease. So, well, I'll hope to convince you of that in the coming slides. So our objectives are to recognize the risk factors which can cause these aggressive keratinocyte cancers in immunosuppressed patients. The second is how can we modify factors that help reduce skin cancers in these patients? And then finally, what are some potential treatment options that we can use to help them? So this is just for context. It gives you an idea of how many transplants we do in this country a year. So by far and away, kidney transplantation is the most common, followed by liver, heart, lung, kidney, pancreas, and then combination intestine, pancreas, and heart and lung. The reason why this is important is it turns out that the amount of immunosuppression that's required to prevent rejection, it's different depending on the type of organ you get. So for example, the highest degree of immunosuppression is required for lung, heart, and these combination transplants. The lowest is liver, and then kidney transplantation is somewhere in the middle, but it tends to be a little bit on the higher side, if you will. And this is just kind of a history of organ transplantation. If you look back, I think there are reports of transplants even hundreds of years ago. The problem was rejection. So essentially what was recognized even more than 100 years ago was that when you would transplant an organ into a recipient, what seemed to happen was within a few days or weeks, these patients got very sick and often rejected their organ and often would even succumb and pass away after this procedure, except in identical twins. So there's something about identical twins that prevented this type of rejection. So pretty soon, as the field of immunology emerged and we got better at recognizing these types of things, it was realized that you had to suppress the immune system to prevent rejection. So the first successful kidney transplant was done in identical twins in 1952. But again, as I said, it was limited to identical twins for many, many years. As we began to realize the powers of radiation, then this became a little bit more widespread. So radiation, whole body radiation, was used to suppress the immune system even in the early 60s. And what we found was that you'd prevent rejection, but this type of radiation was very toxic. So often people would die from the side effects of this high dose radiation. But in the mid 60s, we started to use oral medicines that you could titrate. And what we realized, it wasn't a zero-sum game. So you could suppress someone's immune system to the right amount and prevent rejection, but patients would also survive. So the first sets of medicines that were used were Imuran, which is also called azathioprine, and 6-mercaptopurine. These are still used today. And then in the late 60s, prednisone was being used more widespread. And then in the early 80s, things changed a little bit, and cyclosporin was identified. And often, as I said, these medicines are even still used today. So that combination of Imuran, cyclosporin, and prednisone, it basically persisted for decades until the 90s, when a cousin of cyclosporin, which was called tacrolimus, was being used, and that had fewer side effects. And then in the early 2000s, a newer medicine called sirolimus began. We started using that in earnest. And what's interesting about that is that medicine has been around for quite some time. But the reason why I have a picture of the Easter Islands, those sculptures are very famous, is because the native population of the Easter Islands, they seem to be immune to tetanus. So tetanus is a condition that was seen in lots of similar islands with horses. So there were lots of horses on the Easter Islands, but the natives who lived on the Easter Islands were immune to it. So there was an explorer who thought maybe there must be something in the soil that prevented this type of infection in the natives of the Easter Islands. And sure enough, it was sirolimus. The other name for it is called rapamycin. And over time, we found out that this medicine actually works as an antiseptic, but also helps suppress the immune system. So it can prevent rejection. And even more than that, it seems to reduce the risk of certain types of cancer. So kind of an interesting history there. So in our subset of patients, one of the problems is that you will see a significantly higher rate of skin cancer in solid organ transplant recipients than the general population. In these patients, squamous cell carcinoma and basal cell carcinoma account for greater than 90% of skin cancer. And I will show you in a second, by far, it's squamous cell carcinoma more than even basal cell carcinoma. The incidence increases with duration and extent of immunosuppression. So the longer you're immunosuppressed, and the higher the doses, the greater your risk of skin cancer. So to give you a more concrete idea of who this affects, greater than 50% of Caucasian transplant patients will develop skin cancer. Squamous cell carcinoma is estimated to be between 65 and 250-fold more likely than their baseline risk. Basal cell carcinoma is 10 times more likely than their baseline risk, and melanoma is only 3 times more likely. So when we think of skin cancer, most patients recognize melanoma as being a very dangerous type of skin cancer. So about 8,000 people die of melanoma every year, whereas basal cell carcinoma, it's very rare that people die of that. In fact, less than 500 people a year will succumb to basal cell carcinoma. But what's not appreciated is how many patients will actually die of squamous cell carcinoma, cutaneous squamous cell carcinoma. So this is skin cancer. Almost twice as many patients will succumb to squamous cell carcinoma as melanoma every year. And a substantial number of these are these solid organ transplant patients. So not to get too far in depth, but I wanted to give the audience an idea of how we stage squamous cell carcinoma. So that first cartoon on the top left, it's showing you two layers of the skin. The top layer is what's called your epidermis, and then there's your dermis. And those kind of strangely shaped cells are basically skin cancer cells. So in situ disease, what it means is that the skin cancer is confined to the paper-thin top layer of the skin. So in this case, this would be squamous cell carcinoma in situ. So this is not a dangerous disease. No one has ever died of in situ squamous cell carcinoma. But the problem is it can lead to invasive squamous cell carcinoma. So that's your T1, T2, T3, T4 disease that we're describing there. So when it invades the deeper layer of the skin, that's now called invasive squamous cell carcinoma. And if it's small, that's low-grade disease. When it's wide and it's invaded into the lower layer of the skin, it's a little bit more aggressive. When it's much wider, greater than 4 centimeters, or it's invaded even deeper than the dermis, right? So that's your invasion beyond fat, which is the layer below the dermis, or even starts to begin to invade into bone, that's T3 disease. And if it invades significantly into what's called cortical bone, that's even more aggressive disease. So these are factors that we recognize confer risk when we're talking about squamous cell carcinoma. So we just talked about diameter. So when you look at a factor that correlates most with mortality from squamous cell carcinoma, it's diameter. It's how big is the lesion. But there are other things that are important. So something called differentiation. So when you look at a skin cancer or any type of cancer under the microscope, what a pathologist is looking at is how organized are these cells. So if there's very, very poor organization, then it's called differentiation. It's poorly differentiated. So that's a bad sign. Location is also important. Certain areas of the body, if you make the same skin cancer, it confers a greater risk. So your lip, your ear, these are such areas. We talked about depth. So when you have invasion beyond fat, that's also a bad sign, as well as something called perineural invasion. So when a skin cancer latches on to a cranial nerve, a nerve that's mostly in the head and neck area, right? It's almost like a highway for that cancer to get to the brain. So that's a bad sign. And the reason why this is important is one of the staging systems uses these various characteristics. So you can see if you have one factor, it's called T2A disease. If your tumor exhibits 2 to 3 factors, that's T2B disease. And then if you have 4 factors, that's T3 disease. And you can see your mortality rate increases accordingly. So let's talk about skin cancer in these immunosuppressed patients. So there's very, very important factors that determine risk. So we talked about duration and extent of immunosuppression, but there are other demographic characteristics. So age at transplantation. So it turns out the older you are at transplantation, the higher your risk of developing these aggressive skin cancers. What goes hand in hand with that is the number of skin cancers you had before transplantation. So what it means is that your body has seen enough sun damage that it's already having a hard time repairing sun damage, right? So you need your immune system to help with this process. So if you've already started to develop skin cancer before transplantation, this means that you will likely have more aggressive skin cancers after your transplant. Gender, male patients are more at risk. Patients with fair skin, smoking history, and then the duration of dialysis before a kidney transplant. That seems to be important. So this is what we were talking about before, duration of immunosuppression. So in transplant patients, what you see on that right graph is very important. This is why that risk for squamous cell carcinoma is so much higher than basal cell carcinoma. In non-transplant patients, the ratio of basal cell to squamous cell that we diagnose is about 3-to-1. So basal cell is about 3 times more common than squamous cell in non-transplant patients. But in transplant patients, that number is at least flipped, right? And what happens over time is you can see that dotted line, that dashed line, that risk over time, it almost looks logarithmic. So it doesn't go up linearly. It gets more ominous as time goes on. So these are important numbers. So we talked about earlier the amount of transplantation or the amount of immunosuppression it requires to maintain a graft, an organ. It's different depending on the organ. So liver transplantation requires the least amount of immunosuppression, whereas heart transplantation requires the most. So if you are a heart transplant patient and you develop a skin cancer, there's 100% likelihood that you will develop a second skin cancer. That number is a little bit lower for kidney transplant patients, but you can see it's quite high. It's about 88%. And then what happens is the interval between developing skin cancer, it shortens. So the amount of time between your first and second skin cancer is about 15 months. It's about 11 months between your second and third, and it continues to shorten over time. So this is kind of an illustration of that. This is one of my patients, and you can see in 2016 how his scalp looked. There are, if you, on the left side of the left image, you will see kind of reddish splotchy areas. Those are small precancerous areas. But you can see after 5 years, those small precancerous areas have been replaced by these larger red scaly, we call them patches and plaques. So you can see visibly what that effect of immunosuppression over time does to patients. And these are those factors that we were talking about earlier. So pre-transplant skin cancer seems to be a very high indicator of developing more aggressive skin cancers after transplant, as is male gender, Caucasian race, and then being over 50. What's interesting is when you look at where skin cancers are diagnosed in transplant patients, before 40, if you have a transplantation, usually those skin cancers are seen on the upper extremities and the trunk. And it takes about 8 years to develop your first skin cancer. This is important because, I didn't mention it, but kind of baked into the staging system of squamous cell carcinoma has to do with anatomy. So we talked about your ear and your lip being high-risk sites. Your head and neck in general tends to be higher risk than your trunk, than your arms, than your legs, etc. So after 60, 80% of the skin cancers we start to diagnose are on the head and neck, and it only takes about 3 years to develop that first skin cancer. So this again is an image illustrating that point. So this is one of my patients who developed he had a kidney transplant in 2009 at the age of 39. And he was started on 2 medicines that we mentioned earlier. These are transplant medicines. They're called tacrolimus and Cellcept. And he developed his first skin cancer. It was about 3 years later at the age of 42. But then he didn't have anything for 5 years. But then after that, you can see they started to come in waves at shorter intervals, 2017, 19, 21. I should have warned you before. This is if anyone's eating lunch. Some of my pictures are a little bit graphic, so sorry about that. What you see here illustrates some of the more aggressive skin cancers in these organ transplant patients. So in general, when you're grouping all transplant patients together who develop skin cancer, there's about a 13% recurrence rate and an 8 to 10% rate of metastasis. So this is significantly higher than non-transplant patients. Poor prognosis, squamous cell carcinoma on the head, older age, history of extensive sun exposure. So again, this is real life. This is a patient of mine. So he walked into one of my general clinics and he looked like this. And his story was that he has a history of rheumatoid arthritis. So he has a history of immunosuppression. So he's been on prednisone on and off for 30 years. And he only had about 2 to 3 skin cancers before his transplant, but he still had skin cancer before transplantation. So he developed, or he had his transplant in 2000 and was started on that older cocktail of prednisone, cyclosporin, and Imuran. And he was on that for 10 years. And he developed greater than 50 skin cancers since his transplantation. And then he presented in 2019 looking like this to establish care. So we'll come back to him later, but I kind of wanted to show you his picture before we did any workup or any treatment. So this is a cartoon of photocarcinogenesis. It's similar to any type of carcinogenesis, or the process by which a cancer is made. So you have some type of inciting event and maybe a genetic predisposition. In this case, the inciting event for us is sun exposure, ultraviolet radiation, and you develop some type of a mutation. And then over time, there are various genes that may not be working correctly, and that leads to promotion of these skin cancers and then progression. So not only do you develop it locally, but it starts to potentially move other places and metastasize. So skin cancer is no different. What I wanted to show here is the importance of the immune system locally. So it turns out that even in immunosuppressed patients, sun exposure seems to have a local immunosuppressive effect. And the way that it does this is it kind of changes the ratio of immune cells that are in the skin. And it turns out that our immune system, it's basically like a series of green light and red light, right? Stop, start, stop, start. And if you change that and you alter the balance in such a way that you can have more red lights than green lights, you inhibit your body's ability to mount an immune response, and that greatly increases your risk of skin cancer. So the other thing that happens when you're immunosuppressed is you decrease immune cells that are responsible for surveillance. So if your immune cells are not on patrol, then they miss a spot, right? Or many spots. So that's kind of what we see here. And the other thing that may happen, particularly with squamous cell carcinoma, is when the immune system is suppressed, there's certain viruses that begin to have free reign. And when these viruses become very, very active, they may contribute as well to the progression of these skin cancers. So this is an example of that. This is one of my transplant patients, and she came in with these, you can see these red kind of scaly patches and plaques again around her nails. So you can look at it and you can say, wow, these kind of look a little bit like warts. And you're right, they do. But it turns out that in transplant patients, sometimes these wart-like lesions can actually progress and become skin cancers. And that's what happened with her. These are all actually skin cancers. And you can see the degree of invasion that she had and the surgical intervention that was required, which can be disfiguring.
All right, we have our first, since our practice, our first poll everywhere question. And so which of the following is the most common skin cancer in transplant patients? And would that be A, melanoma, B, basal cell carcinoma, or C, squamous cell carcinoma? And take 10 or 15 seconds to think about this. Again, this is all anonymous. Dr. Jolly, this is fascinating. I'm already learning a lot. Thank you so much.
Of course. I'm glad.
All right. How are they doing?
Very well. Very well. So may I tell them the answer?
Yeah.
Yeah. So most of you got it. The answer is squamous cell carcinoma. So remember, this is which of the following is the most common skin cancer in transplant patients? So that would be squamous cell carcinoma. In all comers, in non-transplant patients, the answer is basal cell carcinoma. So the correct answer in this case is C. Very good. All right. So the next step is to give you all a basic background in the types of immunosuppressive medicines that we use and that we see in the clinic. So don't be scared by this slide. I know this is an intimidating slide, but it's just to give you an idea of kind of what happens between immune cells and where the targets are. So you can see this is basically, there are two cells here. There's what's called an antigen presenting cell. So these are like those Langerhans cells that I described earlier that are depleted in immunosuppressed patients. And what happens is these antigen presenting cells usually they see either some type of infectious agent like a bacteria or a virus or even a tumor. And what they do is they swallow up these cells and then they spit out a piece of it, which is called an antigen. That's the AG. And they present it to a T cell. So these are the cells on the bottom half of the screen. And what happens is once that signal is initiated, then there's a cascade of signals that happens. So you can see signal 1 starts, then signal 2, and then that basically revs up your T cell to stimulate this third signal. And then you start to make T cells that become active and alert to these tumors in this case. So that's normally what happens. So in a patient who receives a transplant, if you have this unabated activation of T cells, what will happen is you'll develop rejection. So over the past 50, 60, 70 years, this has been the riddle. The riddle has been to how do we suppress this T cell, but also not impair your body's ability to fight things like infections and cancer. So these are certain medicines that we use to inhibit this reaction, right? So we talked about cyclosporin and tacrolimus earlier. So these inhibit something called calcineurin. In a second, I'll tell you about these newer medicines. These are antibodies that inhibit a receptor on your antigen-presenting cells. That's something like belatacept. And then we have other newer medicines, this sirolimus that I was telling you about that we found in the Easter Islands that inhibits something called mTOR. And then the older medicines, your Cellcept and your Imuran, these inhibit the proliferation of T cells. So the approach to immunosuppression that your nephrologists, pulmonologists, cardiologists use with their respective transplant patients are as follows. So it used to be that we were limited to the first three classes, class A, B, and C. So for example, if you had a heart transplant, which requires greater immunosuppression, that specialist would choose prednisone, which is a steroid, something like cyclosporin in class B, and then Imuran in class C. And then over time, that specialist has switched now and is using plus minus prednisone, but they're using tacrolimus and Cellcept. But now, over the last decade or so, since I've been in practice, we're starting to see these newer class of medicines. So class D, these are your mTOR inhibitors like sirolimus. And then this newer class, these antibodies, class E. These are less immunosuppressive, so their risk of skin cancer is lower than class A, B, and C. But the problem is they may have some of their own side effects. So it's a tricky balance, and it's still a bit of an art to manage immunosuppression in patients. So these are calcineurin inhibitors. So this is cyclosporin and tacrolimus. And the reason I'm showing you these slides is one of the reasons why certain medicines, let me back up. So not all immunosuppression is created equal, right? So certain medicines are worse in terms of conferring skin cancer risk than other medicines. So while there are two calcineurin inhibitors, it turns out that cyclosporin increases one's risk of skin cancer much more than tacrolimus does. And the reason why is it has another effect besides your typical immunosuppression. So it inhibits a process called apoptosis. So when a tumor cell is recognized, your body can promote a signal that leads it to almost kill itself, right? It's called apoptosis. So it turns out that cyclosporin inhibits this. So it allows that tumor to grow, whereas tacrolimus doesn't do that. And then those older medicines that we talked about, your Imuran and Cellcept, they both inhibit DNA synthesis in these T cells, right? But the problem is the Imuran, it has a peculiar side effect. A metabolite of it, it actually incorporates into DNA. And when it does that, it promotes mutations in the DNA, which is why this confers a greater risk of skin cancer than the CellCept does. So this was just to give you an idea that some of these medicines seem to be worse than other ones in terms of conferring skin cancer risk. So this gives you an idea. So this was a patient of mine who had a liver transplant at 50. So she had a significant tanning bed use before transplantation, but she never had a skin cancer. So liver transplantation, remember, they require less immunosuppression than other types of transplants. However, she was started on Imuran, only Imuran. And 6 months after starting Imuran, she developed her first skin cancer. And over 1 year, she developed 10 other skin cancers. So you can see how potent that effect is of that medicine. Again, apologize for the graphic nature of this picture, but it illustrates a point. So voriconazole is not a medicine that we use to prevent rejection of transplant patients. It's actually an antifungal. So what happens is these patients often will develop things like pneumonia, often a fungal pneumonia, and they'll need to be on potent antifungals. So voriconazole is a medicine that used to be very commonly used. But it turns out that this, kind of like the Imuran, it incorporates itself into the DNA of these patients, of their cells, and it also allows these tumors to kind of run rampant. So these patients will develop very, very aggressive squamous cell carcinoma as well as melanoma. And this kind of illustrates that point. So this is a patient of mine who was a heart transplant patient, and he developed a fungal pneumonia, and he was started on voriconazole. And a year later, this is how he looked. So you can see he developed, these are all squamous cell carcinoma and large aggressive squamous cell carcinoma. And he unfortunately did not survive very long after this. The reason why this is important is there's an easy intervention. So we can work with our infectious disease colleagues and have them use other antifungals instead of this, right? So this is why it's important, and one of the big things that we educate our residents about and other dermatologists about as well as other specialists. And I think our providers here at UNC are pretty good. They're all now quite familiar with this side effect, and they avoid this medicine whenever possible. So these are our mTOR inhibitors. So this is sirolimus, right, is the most common one that we use. These are the compounds that were found in those Easter Islands. So what's really interesting about this and what was very exciting was this was a New England Journal paper in 2012, was that sirolimus seemed to prevent rejection in transplant patients, but it actually seemed to lower one's risk of cancer. Right. So it's the best of both worlds. You could, prevent rejection of their graft, but also reduce one's risk of cancer, particularly skin cancer. So this was quite exciting. Like most things, however, it turns out that it's probably not as good as originally advertised, but still better than all of those other medicines. The problem, and people will say, well, why doesn't everybody just go on this? It turns out there's side effects. So a big side effect is impaired wound healing, but there are other things that can happen. So a lot of times our transplant doctors will try this medicine, but patients will not be able to tolerate it. That's one of the big issues. All right. So in a second, we will discuss kind of our approach to managing these solid organ transplant recipient patients. So we'll go in detail in a second, but I just kind of wanted to give you an overview. So hopefully I've convinced you now that immunosuppression is not created equal, and we should always, as dermatologists, be reviewing our immunosuppression options. There are also other ways to prevent skin cancer. So we haven't really talked about sun protection, but it turns out that there's, in addition to sunscreen, there are different vitamins that we may be able to use that can help these patients. Triage is important. So a lot of times when these patients develop skin cancer, they'll be covered in so many, it's hard to know which ones to treat. So this idea of urgent versus important is an important concept. We will discuss something called field treatment, and then having a multidisciplinary team is sometimes necessary as well.
All right, and here's our next question. Which of the following medications confers the lowest skin cancer risk? Dr. Jolly, I'll let you pronounce these all because I know you'll do a better job than I will.
No, I'm sure you would do just fine. So cyclosporin A is the first one. Sirolimus is the second one. As an aside, I'm impressed, audience. C is azathioprine, also known as Imuran, and then D is voriconazole.
All right, and again, take another 10 seconds or so. Thank you. Folks are already jumping on the answer there. And again, just a reminder, while we're waiting, please be jotting down your questions, and then we'll take as many of those as we can later on in the presentation. All right, how are they doing?
Very well. I'm impressed. So sirolimus is the correct answer here. All right. So these were our approaches to helping these patients. So the first step is to examine their immunosuppression regimen and see if there's opportunities there. So this is, again, sometimes it's easier to demonstrate this clinically than it is just by giving you a bunch of texts. So this is a patient of mine who developed numerous warts and skin cancers, and these were all really, really difficult to treat. So she was developing warts on her feet, skin cancers on her extremities, her hands and her feet, and I tried everything to treat them, and it was just like, one step forward, 5 steps back. And she was a kidney transplant patient, and about 5 years after her transplant, unfortunately, she developed signs of rejection. So the nephrologist got her prepared for a second transplant. But normally what happens is they don't remove immunosuppression in these patients. So she still needed to go back on dialysis. So we asked if they would at least reduce her immunosuppression. So they said, yeah, we don't want to take her off of it because it makes her chance of rejecting her second organ less if you keep her on some amount of immunosuppression. So they reduced her immunosuppression by half. And what happened was everything melted away. So within months, in some cases weeks, you could see how the warts and the skin cancers, just kind of completely went away. She was thrilled. All right, photoprotection. So we've had 2 Nobel Prize winners in science here at the University of North Carolina. So this is Dr. Aziz Sanjar, who won a Nobel Prize in 2015 for his work with an enzyme called photolyase. So it turns out that we in our body have a toolbox, and we have a fairly extensive arsenal of enzymes and proteins that repair DNA damage. But we don't have this one. So this photolyase, unfortunately, we don't have. And unfortunately, this is actually much better at repairing DNA damage than the stuff that we have endogenously, right? So it's like having the wrong size Allen wrench, right? So what Dr. Sanjar did is he was able to work on this enzyme, and he found that it works. It's really, really impressive how efficient this enzyme is at repairing damage. So normally when we do it in our body, it takes 5 or 6 steps to repair damage. So you need, again, using that analogy, just 5 or 6 different tools, whereas this one enzyme does everything. It does everything all in one, right? So it recognizes the damage, it removes the damage, it repairs the damage. Again, the problem is we don't have it. So wouldn't it be great if somebody made a sunscreen that contained this enzyme? And that's what they did, right? So this is a Spanish company that created this, and there's numerous now that have incorporated this enzyme into their sunscreens. And it's still early to tell exactly how effective these sunscreens are, but I tell my transplant patients about them. They're a little bit pricier, but the data suggests that there's at least a trend that these patients, their risk of skin cancer is a little bit lower than if you use conventional sunscreen. So there's something called niacinamide, which is a cousin of vitamin B3, which is called niacin. So niacinamide seems to help with a lot of different things. It helps with arthritis, with diabetes, and then even various skin conditions like acne, skin cancer, and hyperpigmentations when people develop dark spots. So don't worry about the data here, but it turns out that when patients take 500 milligrams of niacinamide twice a day, you can reduce your risk of skin cancer by about 20 to 25%. Doesn't sound like a lot, but in my world, that's a lot. It's like free money. This is a $10 supplement that's quite safe to use. So this is something that we've been telling our patients about. There's another over-the-counter supplement I wanted the audience to know about. It's called polypodium. So polypodium is an extract from ferns, from plants, and it also seems to help repair sun damage and also may help reduce one's risk of skin cancer. And actually now there's a product that contains both this polypodium and our previous niacinamide. So that's kind of the product on the bottom. All right. The next thing I wanted to mention is something called field treatment. So in dermatology, we use numerous either creams or devices like lasers and lights to help kind of reduce and repair sun damage. So essentially what happens is patients will, let's say they'll apply a cream on an area like we see in the image on the right. You'll do it for a certain period of time and patients will generate a reaction. So it'll oftentimes, I describe it as looking like poison ivy. That's not a bad thing. It's good. They're generating an immune reaction, and often that will clear or at least help significantly reduce these precancers and early skin cancers. So cycling between them. So these are different types of field treatments. So you don't have to know what they are, but again, there are procedures, devices and creams that we use. And mostly nowadays it's creams. It's this 5-fluorouracil that you see on the far left. That seems to be the most effective way at doing this, but that's a very important tool in our arsenal. So this is a patient who had all of these kind of red splotchy areas. You can see our precancers and early skin cancers. So he did this field treatment and you can see kind of this improvement that he got. But this illustrates the need to continue to do this. So then I didn't see him for a few years, and then he came back, and basically they were all back, and some were even worse than they were to begin with. So this isn't, unfortunately, a one-time thing for these patients. A lot of times this will be, rinse and repeat several times a year. So there are also oral medicines. So retinoids are basically oral vitamin A. And this is a medicine that we will use in patients who start to look like this patient, where they start to make too many that we can treat practically. The problem with this medicine is it's got its own set of side effects, and there's a window of time when you can use it. So my point is not that you know necessarily what it is, it's to kind of demonstrate the limitations, right? So it's much more important to prevent a patient from getting to this point than trying to correct it later. It's much more difficult to correct it. So what about immunotherapy? So your audience is probably quite familiar with immunotherapy. So this has been revolution in the field of oncology, and skin cancer is no different. So immunotherapy for melanoma and things like squamous cell carcinoma have really changed the game in this field, except when you use it in transplant patients. Right. So theoretically, the idea is if you use immunotherapy in transplant patients, these patients will almost surely, they will reject. Right. So that's been the big roadblock and the hindrance in my world. Except that, before I go into that, let me show you another cartoon. The way that this immunotherapy works, remember I was telling you your immune system is basically, it's a series of red lights, stop, or green lights, go, right? So in this case, this cartoon shows that signal 1 and signal 2 that I showed you earlier. So this antigen presenting cell is telling a T cell that there's an antigen there. There's a second signal that is saying, okay, yeah, we are a go, but there's this one last signal, this PD-1 ligand, which is on these antigen presenting cells, or the PD-1 receptor, which is on T cells. So in this case, what's happening here is this interaction is preventing this proliferation of T cells. And the reason why, you can say, well, why would that happen? So it turns out that our body sometimes makes mistakes. So this could be an autoantigen. So this could be an antigen from our own, one of our own cells. And if this reaction were allowed to go, then these patients would develop something called autoimmunity. So this is why it exists, right? So it exists so your body has checks and balances, and this is a way to stop it. Now, when this receptor is not engaged, there's a green light, and your T cell says, "Okay, I've got it. I know what I've got to go attack, and I'm off to the races." The problem is that tumor cells are very clever, and they also express this PD-1 ligand. So you can see here, this tumor cell is expressing an antigen that this T cell has recognized. But this PD-1 ligand on the tumor cell has engaged the PD-1 receptor on the T cell. And it's telling the T cell, hey, listen, there's nothing to see here. Don't worry about it. Sleep, right? And there's a big red light that's there. So this is what immunotherapy does. So when this clever tumor cell comes and it tries to engage that receptor, there's an antibody. So this is your nivolumab, or in my world, something called cemiplimab, these antibodies that prevent the interaction between PD-1 ligand on the tumor cell and the PD-1 receptor on the T cell. And it's very potent. As you can see here, this medicine called cemiplimab, which is the antibody that we use immunotherapy in squamous cell carcinoma, these patients have almost a 50% overall response rate, which is really very impressive and significant. So the question then becomes, is there a way that we can use these medicines in transplant patients? So again, theoretically, the problem was, if you start stimulating the immune response, which is what's happening here, these patients will almost certainly reject their organ, right? Maybe not. So that's kind of what this pilot study is showing. So these were 7 patients with advanced squamous cell carcinoma. So these patients have metastatic squamous cell carcinoma or squamous cell carcinoma that cannot be treated by radiation or by surgery. And what they found was that 3 out of 7 patients had an overall response. So 50%, just like our non-immunosuppressed patients. Unfortunately, three patients did progress. One had stable disease, which we consider a victory, and only 1 out of 7 rejected their kidney. So this is a rejection rate of about 15%. Previous studies have shown rejection rates of about 40 to 50%. But these were in non-skin cancer patients. So the reason why this is important is you may be able to tolerate this treatment in skin cancer patients more than you can in other types of tumors. So that's I think what I have there.
Great. And one more question here. Which of the following approaches help reduce skin cancer risk in transplant patients? And again, I'll let you go ahead and present the answers, please.
No problem. So A is that vitamin that I discussed, the niacinamide. B is switching to an mTOR inhibitor like the sirolimus, as we discussed earlier. C is adding a retinoid. So those are those oral vitamin A medicines. And then D is all of the above.
Great. And take just a few more seconds for the audience, but looks like they're on the right track. How are they doing?
Very well. So the answer is all of the above. So coming back to our patient that I saw in my general clinic that day. So this is what he had, and what ended up happening was I biopsied a few of these lesions, but I also did a lymph node exam. And when I did a lymph node exam, I could feel a lymph node in his left underarm. And this is showing bulky lymphadenopathy under his left underarm. You can see the top is a CT scan. The bottom is what's called a PET scan. So he had surgery and he had radiation. But the problem is he has probably 6 or 7 of those types of aggressive cancers. So we spent a significant amount of time, effort, put him through surgery, a big surgery, radiation, and that was September of 19. In March of 20, he came back with this. So this is another aggressive skin cancer. And he wanted to be aggressive with surgical treatment. So you can see what happened here. He had surgery and he had to have this is called a free flap. So surgeons were able to take a piece of skin from another part of his body and stitch it to his forehead. So that's now November of 2020. The problem is in December of 2020, you can see near his right brow, he developed another nodule. So this is playing whack-a-mole with that same tumor. You can see kind of what happened there. And then this is, April 21. He had another surgery and for that brow lesion, but then same thing happened in 21. So you can see he really suffered that last year and a half. So this is our strategy. This is what we talked about, revision of immunosuppression. So when somebody does develop metastatic squamous cell carcinoma, greater than 10 squamous cell carcinomas a year, a new case of Merkel cell carcinoma, people now, that was something that most people didn't recognize, but after Jimmy Buffett's passing, a lot of people now recognize that. So that's another type of skin cancer. So essentially, we try to lower the dose of immunosuppression. We move from 3 drugs to 2 drugs. We try to switch to these mTOR inhibitors or those antibodies that I mentioned earlier. We try to put them on that oral vitamin A, the retinoid. And in kidney transplant patients, you can stop immunosuppression altogether and start these patients back on dialysis. So that is an option, but a lot of times these patients don't want to go back on dialysis. So the one other thing I would add here is maybe this new immunotherapy, we need to continue to work on that, and that may provide some more hope even to these patients. And these are my references if you're interested, and then thank you so much for your attention.
Great. Thank you so much, Dr. Jolly. Let me go ahead and open this up to our Q&A slide here, and let me just check to see if we have any questions that have already come in. Bear with me for just one moment. All right, so none yet, but this is your opportunity for all of you in the audience to go ahead and share those questions through Poll Everywhere, and we'll go ahead and take as many of those as we can. I had jotted down a few of my own. First off, I wanted to mention that I breezed right through our intro and I forgot to ask you. So we talked about your professional bio, but what's something outside of that we should know about you?
Yeah, so I over the last year or so, I've picked up a rather unhealthy hobby of making homemade pizza. So,
good for
so
you.
Yeah.
How are you doing?
Maybe not that good for me, but nonetheless.
Yeah,
that's right.
Are you doing the outdoor oven?
Yes. I purchased one of those outdoor ovens and learning how to make dough, and so it's a lot of fun.
Yeah. I think baking is very satisfying.
It is. Yeah.
Well, let's say, and I was glad you explained the Easter Island comment because, or the image there, because I was trying to figure out where to
That's
see
right. That's right. Yes.
Those statues from Easter Island. Let's see. I also wanted to ask, again, let me just, I'll check in a second to see if there are any others. But But I was just thinking about CAR T because I was actually just at the Advanced Cellular Therapeutics facility yesterday and visiting there for the first time. Anything out of the CAR T research that's an intersect with what your work is focused on?
It is. It's exciting. You know, that's the emerging technology in so many types of tumors, and skin cancer is not different. So in the field of melanoma and even in squamous cell carcinoma, I think there's a very, very important role for it.
Good. Let me check again on our questions and see if we have any that, we've got a bunch. Here we go. All right. Let me, we do have some thank yous, but I'll jump right in to the first question here. Let you take that.
So the question is regarding voriconazole use. Is there a length of time that correlates to the increased risk of squamous cell carcinoma? It's a really good question. It depends on the context. So, for example, we still see patients who are on voriconazole, who are transplant patients. As a dermatologist, when I see that, what I try to do is, as we said, context is important. So if it's a patient who's already had skin cancer, then I will talk to the infectious disease specialists and ask them to switch immediately. Because even a month of voriconazole use can increase one's risk of squamous cell carcinoma. However, if you are a patient who's not had skin cancer before and a new transplant patient early, then it might be okay to use that. But again, when I see that medicine, I usually at least have a discussion.
And here's a great follow-up. Have warnings been added to the medications?
Yeah, so something like you asked, the previous question about voriconazole. So what we know about voriconazole is that it can cause photosensitivity. So that is definitely there. Risk of skin cancer is also there, but it's buried with, 100 other things.
All right. So would local intralesional deliver of checkpoint inhibitors be beneficial?
Very good question. Potentially. So I use actually intralesional 5-fluorouracil, which is conventional chemotherapy, and it works quite well for certain types of skin cancers. So potentially this would be a great idea.
Great. And is the photolyase sunscreen advisable for other immunocompromised individuals for skin cancer prevention, or even just for the general public?
Yeah. So absolutely, it's available. It's a little pricier than conventional sunscreen. So that's why, I will tell patients about it who are interested in learning more about photocarcinogenesis and sun protection. But yes, absolutely, anyone can use it.
All right. And would you suggest an average healthy person, very similar, to take photolyase topically, niacinamide, 500 milligram, PO, BID, and the polypodium to prevent skin cancer? And I was wondering the same thing.
Yeah.
What about that combination?
Not necessarily. I think what's much more important is sun protection in the way of conventional sunscreen, and even sun protective clothing. So I'll tell you, I didn't really talk too much about that, but I grew up in Miami, and when I grew up, we didn't really know we called sunscreen suntan lotion, right? And there's actually a backstory for that. There's a reason for that. But sun protective clothing, that's, the long sleeve shirts that have embedded either sunscreen or the way that the fabric is woven, that's quite effective. So, even now, if I go to the beach or something like that, I'll wear that. I'll put sunscreen on my face. If people wear wide brimmed hats, that's probably something that's more practical. I don't think someone without a history of skin cancer needs necessarily to take a photolyse containing sunscreen, niacinamide, or polypodium.
Great. Thank you so much. And thank you so much. Great lecture. We had a few comments like that. Not surprised.
Thank you.
I agree. We want to say thank you to the University Cancer Research Fund and the UNC Lineberger Comprehensive Cancer Center We want to say thank you to the staff of the UNC Lineberger Cancer Network. That's Benny Obore, John Powell, Oliver Marth, Barbara Walsh, Andrew Dodson, Patrick Muscarella, and Lindsay Reich. Thanks to all of them. They each play a role in making these happen.